that sometimes it takes up all of our bandwidth, but sometimes when we get to a sort of steady state that works for us, we start thinking of, what can I do to make my life easier for myself in the future? So I can have the life that I want to have. I can live a long and healthy life and be as mobile as possible. And I think we all have different goals in that, right? Like I just want to go on a round the world cruise with my husband, or I want to mountain bike until I'm 80. We all have something different in mind. So I wanted to share just one observation before we get started, because we have four amazing clinicians to share some knowledge with us. And then following that at about 7 o'clock, we'll have our peer panel. But before we get started, I just wanted to say, I don't know if you have some of you have the same recollection, but I'm pretty sure every time I've seen a physio at GF Strong, they've said, but what about your shoulders? and it's true. What about our shoulders? What about my shoulders? I'm now asking what about my shoulders every day. And it always made me laugh, and it wasn't until I was about 40 that I actually thought, oh, I wish I'd asked that question earlier. So, and I remember seeing the outpatient nurse once at GF when I was 24 or so. I think that was Christine Zarowski. And she said, you old guys, 24, really? Anyway, people who have been doing bladder management a long time, you old guys, you never want to change. And in my career with spinal cord injury VC, I have seen that myself in my colleagues and in our peer community. It's hard to change. You find something that works and you just want to keep doing it forever because you can rely on it, but our bodies change. So tonight's about how to make those changes, how to keep up with your body's changes, and how to kind of like nudge it in the direction you want to go. And our very first speaker is Dr. Viet Vu, who's going to sort of open us up into this conversation. So,
hello, everyone. So I'm Dr. Vu. I work at GF Strong, and I recognize some faces in this room. When I was asked to do this talk, it was kind of a general ask, not like what do you want to specifically speak about. And we're going to talk about aging, but it's not really aging. It's just living well and healthy with a spinal cord injury. And I figured this is my chance to kind of like talk to my, patients or non-patients about what I really want you to take away. So it's a very top-down 10 things that I would like to remind you. And it's not just me. I had feedback from colleagues and people with lived experiences. So super casual, chime in if you have questions, okay? Okay, so this is the general list, and then I'll go through each individually. Okay, starting from the head. Socializing, engaging, the fact that you're all here is a brilliant first step, right? Like talk to each other, talk to peers, talk to your clinicians, and finding the way to talk about your spinal cord injury. I think in the beginning, I'm sure everyone has figured out how to describe their injury to friends and family. But yeah, just that mental health piece, I don't think we acknowledge enough. Like we're lucky at GF Strong to have a psychologist, but I feel like when people leave GF, it's really hard to find supports. Secondly is your heart. We talk about cardiovascular health all the time, but really it is, how do you keep moving? Even with paralysis, you still need to keep moving to keep the blood flowing. Third, the lungs. I will say don't smoke, breathe well, but there's a lot to it because pneumonia sucks. Pneumonia is the #1 killer after spinal cord injury, right? Like the respiratory function is compromised. So we'll cover that. Arms. I think if you ask anybody in a manual chair, it's gonna be the freaking shoulders. So we'll cover that too. Legs, who has broken a bone in their legs? Was it your knee, around femur, or hip? Okay, so super common. But again, it doesn't happen right away. It happens over a long period of time. Bladder, number one concern usually, and it does change. Bladder management changes after decades living with a spinal cord injury. Bowel care, again, top three, right? Like it's hard to manage. And it changes when you travel, when you're stressed, when your diet changes, when you're on antibiotics. So we'll talk about that. Sexual health. This is the mecca for spinal cord injury and sexual health. So make use of it. Then the skin. A lot of people have had issues with skin breakdown, even decades in, right? So this is the one sort of risk factor that doesn't go away with time. And then the last one is kind of a nebulous thing, but know your body, know where your sensation is, know your level of injury, know what your strength is, because as it changes, you're gonna have to describe to some doctor or clinician what your changes are. So to know what your baseline is to what it is currently is really helpful, right? Even know your blood pressure, know your weight, who has weighed themselves recently. Like we have scales at GF Strong, there's scales upstairs. For folks that aren't near here, like find a way in a community center to get your weight checked. Okay, so let's dive in.
Funny, Monica. I had a cute guy look me up at a gym once just to stand on the scale with me. I was like, excuse me, are you that me?
Every week, please.
Yeah.
Okay. The head, mental health. So these are the categories that I'll break it down. What I want you to focus on is the mental health and well-being. What worries me is isolation, depression, even suicide ideas. For the third column, what is it that you can do is to be proactive, to connect with people and socialize and keep learning. Sounds all very easy, but it's not when mobility is challenging. So what I would recommend is to find the groups. Like we're lucky in British Columbia, there are lots of rec therapy groups, community groups that are, if you're into sports, there's skiing. If you're into ballroom dancing, there was ballroom dancing. I'm not sure if that's still happening. Is it still happening? Yeah. Yeah. And are the coffee groups still happening?
Yeah, all over the place.
Perfect. Yeah. So please just find a peer, because more often than not, you'll be surprised, right? Like you can commiserate and find somebody with shared experience. Second is the heart. Like I said, cardiovascular health. I don't know how clear, it's not like this tangible, granular thing when we talk about cardiovascular health, but I think what is tangible is heart attack, stroke, right? We all know somebody who's had a heart attack or stroke. And with paralysis, you can't do all of the exercise to control cholesterol. So it's really important, it's really important that you find something that's fun to keep you active. And then when you go to your doctor every year, get the metabolic panel. Even that is a bit nebulous. So it's glucose to make sure you don't have diabetes, cholesterol to make sure it's not high, because there's treatment, electrolytes, liver panel, kidney panel. Okay. And I know there's a shortage of GPs, and I wish there was an easier way for people to find GPs. But if you live, I'm assuming you all live in coastal. So there's, a list that you could go on to find a GP. And then even in, for those online, VHA, the Interior, all have lists that you could go on to get a GP. Breathing. At GF Strong, we do check for sleep apnea. It kind of goes hand in hand following spinal cord injury. And thank you for that yawn. It's Jay-Hon, can I admit that? Sorry, okay.
Let me do it.
Thanks, Terry. So we do check for sleep apnea, but again, it's not always done. But for something that's so prevalent, it's really hard to get done when you leave GF Strong. But if you're having issues of daytime sleepiness, snoring at night, or like you stop breathing and you gasp for air, or even like thinking and concentration is difficult, make sure sleep apnea has been checked. And then smoking. I don't know why it's still such a thing in 2025. Like, we have so much information to say that it's so bad for your body, every system in your body, but yet nicotine is very addictive, right? So it's hard. But if it's one thing you can do is to stop smoking. And then the last thing that worries me, like I said, pneumonia is the #1 killer. If you have a neck injury, it's hard to cough, you know, for the thousands of times that you cough when you have a cold, even. I can't imagine when it goes down to your lungs and you have pneumonia. So for you to do is to get vaccinated. There's the flu vaccine, COVID vaccine, and if you're over 60, or if you have a tetraplegic injury that's complete, definitely the RSV, the respiratory syncytial virus vaccine. And then the pneumococcal, that should be good for 5 years. So
Those last two aren't covered though, they're actually out of pocket.
RSV is right now, and it's very expensive. I think it's over 300.
A coworker did the pneumonia and, sorry,
People can't hear.
sorry, just
Oh,
to say,
do you-
a coworker did it, it was $600 for both pneumonia and, shingles.
Oh, Zostavax is not, yeah.
Sorry, everybody. It's Alexis Chicoine speaking. I was asking that, the, last two tests, that one pneumonia, the one that was mentioned, isn't covered even by our extended health if you're working, so it can be a struggle to get because of cost.
I wonder if your doctor can justify that on a prescription or something. Because it's covered when you're in hospital. The flu vaccine, pneumonia vaccine. I don't think the Zostavax is covered. No, Andre's shaking his head. But yeah, and if you have any questions about the vaccines, please ask. I'm happy to discuss any concerns. I also work for long COVID, and the number of people who don't get vaccinated because they were fearful, it does put you at higher risk for having long COVID. So what I recommend is to not smoke. People who want to use cannabis, there are other options such as edibles, tinctures. The smoking piece, especially if you have a cervical spinal cord injury, it's really detrimental because it's hard to get that big breath in. So you don't want to also affect the alveoli, the little lung tissue. And if you do have a tetraplegic injury, definitely maintain like your function, your pulmonary function, and monitor that with spirometry. You should know how much air you're able to move through your lungs. And of course, the sleep apnea screening if you're finding yourself like super tired or having a hard time concentrating. Arms, shoulders, Amrit. We have a shoulders class at GF Strong. It's a group, you know, therapy session because it is so important. And I think everybody who's been in a manual chair, even a less so power chair, if you're doing lots of transfers, I could tell you each year I have between 3 and 5 patients who are like, I can't transfer, I'm done. And it's like, I can't admit you to GF Strong. So how do we get you, you know, aboard? How do we get a lift in place? How do we get home care? So the idea is to catch it before. And really, I ask people, count the number, like track the number of transfers you do during a day and divide it in half. You will be saving your shoulders. Not practical, but that is the visual I want you to understand. the force that you're putting on your shoulders every single day. 2 minutes. Oh shoot, I'm only on number 4. Okay. So I had this conversation with Tara Inez, and she's like, shoulders. Like, she was a professional wheelchair basketball. She was super strong. And then all of a sudden shoulders go, and it's like, shit, right? Like, what do you do now? So I don't know how we as clinicians early on can instill this. We haven't been able to have like an effective strategy, like preventative strategy to maintain shoulder health. So help us with that. Legs, make sure, because we're in Canada, vitamin D sucks up here. Definitely take 1,000 to 4,000. Not kidding. I do, like, even for like seasonal affective disorder. But for you guys are like people who are not walking on earth. You are astronauts, right? You are hypogravity. So those bones will become very thin. So do your best to eat the calcium in foods, vitamin D, and then if you bang your leg on a fall, whatever, get it checked. The number of times that it's like, I fell, didn't realize I broke my femur until 2 weeks later, it's kind of too late to have any surgical intervention, or even just to like make sure you're supported and making to help the bones heal well. So definitely get it checked out. And also check the other side, because the other side can also be fractured. Bladder. Drink water, drink water, drink water. I think, and eat less sugar. Bacteria love sugar. So this, I just heard this from Dr. Nigro last week too. So it helps with reducing stone formation. So water, less sugar. Make sure you know a urologist and you see a urologist. In the beginning, we do ask every year, but you know, if your bladder has been stable, bladder pressures are low, they can skip every other year and then every 2 years. So it's doable. It's not that cumbersome. And for men, definitely get your PSA checked. Bowels. I'm sure it's challenging for the majority of folks, but again, drink water, less sugar. The nutritious foods that you need to eat probably don't have a lot of sugar in it. So if you're eating sugar, you're eating less nutritious foods. Get a colonoscopy. Make sure your constipation doesn't become obstipation when you don't poop anymore. There are people who go weeks without having a good bowel movement, and that's not healthy. Your tissue, your large intestine, has the ability to become even a megacolon, so it can get bad quickly. Know your routine. I know we talk about bowel movements like it's, you know, getting my hair done, but it's that important, right? So you need to know like the specifics of how many, you know, what suppository you use, how long it takes, how many ditch stim, like that is all very useful information. Sexual health. Please talk to people. This is top 3 on people's minds after a spinal cord injury, and I'm sure people live with all of these questions. There is a lot of help out there, and like I said, this is the hub for sexual health. Ask us, and for the men, get testosterone checked. For the women, get, you know, if you're aging, you're probably going to go through menopause, right? So hormone replacement is hugely important to talk to your clinician. And then pap smears are not, they do it at Access Clinic at Women's Hospital, but again, you could bring a home pap test kit to have done. Skin. Know every single surface that you're on. Know how you're going to offload, because that one skin breakdown on your ischial tuberosities or your sit bones, that is bed rest in my eyes, right? There's no way of offloading it. So it's almost like an hour in your chair is going to be a week in bed. You don't want to push that, because there are people who've been on bed rest for over a year just to wait for that ischial tuberosity wound to heal. Sorry, and I'm skipping over Ryan's questions at the bottom here. And then the last one, the baseline, like it's so important to know, like you all know your bodies, but to speak to a clinician about your baseline blood pressure, spasm pattern, and then to know what the difference is really helpful. Like I said, we worry about the complications after decades living with a spinal cord injury, but again, we're relying on you to come with that information. And then this green sleeve. So I'm working with Scott Brolin and Fraser Health on this, you know, this provincial spinal cord injury help, a way to reach out to the community, because you know we've got interior people, northern BC people, island people, and they're all saying we're not resourced to manage spinal cord injury. We need help. We need the experts at GF Strong, and we're like, okay, we're here, but how do we extend that help and have it work both ways, because we're dependent on the community to provide that care. So what we thought would be really helpful is if everybody has a sheet of paper, not just with your medications, but like your equipment. I need a chair with this type of cushion, this type of mattress. This is the care I need. I need help with bowel care. I need help with dressing. Because when you go to the hospital, if you could just grab that and be like, this is my next of kin, who to call, that would be super helpful so that people aren't having to figure you out. Okay, thank you.
We have one question from the audience or from the online, and then we'll go on. And that was, someone online wanted to know, what the connection between SCI and sleep apnea is.
There's a lot of reasons. Physiologically, depending on the level of injury, right? So I'll speak to like a cervical injury. Your CO2, your carbon dioxide can also go up after a spinal cord injury. The injury in your throat causes a lot of edema, and then the swelling in the throat leads to obstructive sleep apnea. The CO2 causes more central sleep apnea. The nasal passages, for some reason, even though it's way far away from your neck injury, also becomes swollen and takes up space. Those are like just the intrinsic factors, and then the extrinsic factors, people are on sedatives like baclofen, narcotics. Circadian rhythms are kind of out the window. If you're not working during the day, you're up, and so your sleep cycle is off. Bladder management, like lots of reasons. Yeah.
Thank you so much. We have some articles in the Spin from last year about that, so we'll in the package that we send out with your handout, if you're okay with this. We'll send that out along with the sleep apnea article as well.
Hi, everyone. So my name's Elaine, and this is Amrit, and we're both physiotherapists that work at GF Strong in the outpatient spinal cord injury program. So we're going to talk to you today about the shoulders. So the title of our presentation is, banking on healthy arms. We're thinking about our arms long term and kind of keeping those savings there so that we can use our arms for longer. So just a really quick review about arm anatomy. So your shoulder joint is meant to be very mobile. So you can see on the picture on the bottom, like our shoulder is stabilized by muscles and by ligaments. And then just like the hip, our shoulder joint is a ball and socket joint. However, unlike the hip, the shoulder is not meant for weight bearing. So after a spinal cord injury, often people are using their shoulders more. So if you're in a chair, you're doing things like pushing your chair or propping or weight shifting or transferring. And even if you aren't in a chair and you're ambulatory, you may be using a walking aid or needing your arms for more balance and support. And then also after a spinal cord injury, there may be postural changes, muscle imbalances, and paralysis that can affect the movement of your arms and your shoulders. And then just as a reminder, like it's not just the shoulder that may be affected. You know, your shoulder is connected to the elbow, which is connected to the wrist and connected to the hand. So it's all works as one unit. So this is just a picture of where we see like common issues happening with the arm. So first of all, a lot of we see in the literature and we see in the clinic that most often people are complaining of shoulder pain. And that shoulder pain is often due to things like rotator cuff issues or impingement. And then the next most likely location for an injury is your wrist. So there is a lot of people with carpal tunnel syndrome, for example. And then people may also have injuries to their hands or their elbows, but that's less common than the shoulder and the wrist. And again, of course, we have a picture here of a wheelchair user, but if you are an ambulatory person with a spinal cord injury, again, you may be using walking aids that are putting more pressure on your shoulders, or you may be using your arms for other reasons that perhaps is different than an able-bodied person. Okay, so going back to thinking about our arms as kind of like we have a savings account for our shoulders, and then every day we're kind of making withdrawals from that shoulder account.
This is the money. The account.
Yes. So if we're gonna think about just like a typical day in the life, so, you know, you get up, you gotta roll around in bed, maybe you gotta sit up in bed. Then you have to think about getting dressed. So you're gonna use your arms to get dressed. And then also thinking about, you know, you're using your arms for your regular grooming and your bathing. And then, like Dr. Vu said, we're thinking about all of our transfers that we're doing. So, you know, we're transferring from bed to chair, and perhaps from chair to toilet, or chair to shower, or chair to car, and back again. So thinking about all those transfers that you do during the day as like withdrawals from your arm bank, right? And then, you know, we have to live life. You got to manage your meals, you have to clean your house, maybe you're working, or if you have children or pets, you got to take care of your children and your pets. More withdrawals, right?
Lots of withdrawals with kids.
Yes. And then, you know, we're thinking about mobility. So here we've listed wheelchair propulsion. So, you know, you're wheeling your wheelchair just to go about your daily life, or you're using your walking aid to be walking and getting around from point A to point B. You know, maybe you're using your arms to do your weight shifting. And then we all have to have fun, right? So your recreation also can take from your arm bank if you're participating in sport, or maybe you're doing knitting or any type of activity that involves your upper extremity. And then can anyone think of anything else that they might withdraw from their arm bank? I know we've covered most things, but also, you know, you might consider spasticity or pain if you have pain. If you have an injury to your arm, you know, it's very difficult to achieve like rest for your upper extremity after a spinal cord injury, because you're doing all of these things for your arm with your arms on a daily basis. And then also people may have pre-existing injuries prior to their spinal cord injury, to their rotator cuff, or to their arms. So these are all kind of daily withdrawals that you might take from your arm bank.
And I think about that then multiplied by weeks, and then months, and then years, and then how that accumulates over time. That's a lot of withdrawals.
Money left.
Exactly. So then thinking about it like an account, you know, it's like your RSPs. What do you have saved up then at not the end, that sounds ominous, but towards as you get older? So that's where, you know, what are things that we can consider to decrease the amount of spending or be strategic with spending? And then is there anything that you can do to deposit back into the account? So we have a few things listed here. Posture and position is one. Just thinking about for one, sitting in a seated position, say if you're a manual wheelchair user, how are you sitting all day, and how does that impact how you use your arms? So, you know, if you're sitting in a little bit of a slumped position, that's my pseudo chair, and then you're wheeling, what position is my shoulder in all day, my elbow and my wrist in when I'm doing this? Adding that, so if we can optimize that, you know, as Elaine mentioned, our shoulders are never designed to be our primary forms of mobility. So if we're asking our arms to do that for the rest of our lives, then that's a huge load on them. So how do we try to make it as efficient as possible? Positioning, even relative to thinking about your position in the chair and what effect that has. I think just the position, say, of your wheels, relative to how you're wheeling. Whether they are, if they're further behind for a stable setup, what position am my shoulder and my elbow and my wrist in when I'm wheeling? So small changes, like just the setup of your chair, can decrease the load on your arm every time that you go to propel. And think about that motion times 1,000 times 7 days a week times however many years. It cumulatively can decrease your expenditure. Weight management. It's the elephant in the room, I know. I'm not a dietitian. I won't tell you how much you should weigh, how much you shouldn't weigh, but if you imagine it is more challenging for our arms to move a heavier weight. So it's going to be harder to transfer, it's going to be harder to wheel, it's going to be harder to do most things if you have increased weight to manage. So trying to find that optimal balance of being healthy, having healthy skin, but managing your weight. Choosing wisely. So with respect to equipment, there's been a huge boom in the last few years, or like the last 20 years, changes in terms of what's available equipment wise. So I think, Jocelyn, you mentioned it earlier about people being open and willing to change. So at some point, for manual wheelchair users, do you consider power assist? Do you consider at some point transitioning to a powered chair? Do you consider incorporating a sliding board into your life? Do you consider just taking into consideration the equipment that you're choosing and how it best serves you now and in the future? You may be able to bomb up and down a hill right now in your manual chair, but what's that going to look like in 10 years time? So just planning. Also choosing wisely in terms of your transfers and your, so optimal position and posturing for your transfers. If you think about transfers being something that, you know, your arms are loading all of your weight and your wrists are usually kind of in a maximally extended position, that compressive load is one of the primary reasons why people have carpal tunnel syndrome as a common complaint. And also when you're wheeling, is my wrist in an extended position when I'm wheeling? So thinking about, hey, is there any equipment or changes I can make to my equipment that help to optimize my shoulder position, wrist position, neck and spinal position? Also using wisely. So using wisely, one of the primary reasons, 1 minute, I'll talk fast. Don't speak. One of the primary reasons that people actually get have shoulder and wrist injuries is actually not as a result of improper equipment, but improper use of equipment. So from a poorly maintained manual wheelchair, which even just means not having your tire pressure inflated. That's a simple, low-cost intervention that can really optimize your efficiency in your wheelchair. So check your tire pressure, get your chair maintained, and then learn how to use it. So just being able to learn some tips and tricks of how to use your equipment outside can mitigate a lot of injuries. And the biggest one, and the one that probably will allow you to deposit back into the account, exercise. I know we're a bit biased because we're physios, but even a simple low-cost at-home program of flexibility, of some strengthening and range of motion through your shoulders can help to prevent shoulder injuries from occurring, and then also minimize the pain and impairment from them when they do occur. Like, that's low cost, available to everyone, and you can do it home. And so just think about it, like, you know, you want to have your long-term savings. So you want to have something in the bank to use when you are 20 years, 30 years down the line. You know, the younger that you are, that maybe that you experience spinal cord injury, the longer time period you have where you are actually performing a lot more with your upper body. So thinking a little proactively can lead to a lot of savings.
And you'll see here that, like, even though we were depositing money back into our arm bank, but there's still some left on the table, right? And that's your everyday kind of use of your arms. So if you think about this, like, kind of accumulating over time, we want to save as much money as we can in our arm bank.
we have a few links, QR codes, because we're so high tech, links to a few resources that hopefully could be helpful for people. There is the wheelchair maintenance one there that is actually linked to SCI BC's article on wheelchair maintenance. There are plenty of resources available online for that as well. STOMPS is the exercise program, that is an at-home program that was created at, I think, University of Pittsburgh. And available free resource for everyone. And as well the SCI community page, which has a wealth of information on all things bladder, spasticity, pain management, equipment, and links to resources. So yeah.
Thank you so much. Currently, some of the Q&A, we didn't hear it on the Zoom, so we're gonna have Dr. K give his talk, and then we'll circle back to have a little Q&A before our panel. There's Dr. K.
Good evening, everybody. My name is Dr. Krassioukov. I'm professor of physical medicine rehabilitation. I'm the same specialty as Dr. Vu. I'm some kind of old guy. That's why I stopped doing my inpatient service at Jeff Strong Hospital. I'm only seeing patients in outpatient clinics. And today I will talk to you about one of the most common questions that I received in my outpatient clinic: what to do with my bladder. I'm not a urologist, but I tell you that 60 to 70% of my time in my clinic, I will spend answering questions about
cut it up a bit for you too, okay?
do with the bladder. That's one of the aspects I would like to start, that a lot of research conducted in my laboratories. That's why people interested in research on the bladder, we have few projects on the bladder, and there is a numerous supports I received from various agencies. And one of the aspects which I will talk with you today about some interesting aspects that I developed with collaboration with Coloplast organization you probably quite know. They're producing a lot of urological devices. So one of the aspects which I will start with you. How we know that you have urinary tract infections? It is still very confusing, and I will tell you why. I will talk a little bit about antibiotic resistance, which is very important to understand and then to see what's happening with your bladder. And then finally, I will talk with you about urinary tract infections risk factors. And this project, it was incredibly pleasure to work with a big international panel of urologists around the world. And we developed a specific guide, first of all, for physicians and clinicians to understand why people developing UTI. And then obviously, hopefully, it will give you some sense to understand why and how it's happening. So first of all, definition of urinary tract infections. There are few hundreds of definitions of tract infections, if you know. I presented you three most commonly used definitions: Canadian Urological Association definitions. There is European American Urological Association definitions. There is European guidelines on definitions, and each of them, even though has common theme, but they are different. And this is the problem. That's how we do know that person with spinal cord injury have urinary tract infections. First of all, we know that people who are using catheters will have infections. Depending which catheter, it could help to prevent infections, or opposite, can increase. Sometimes we do know up to 15% of our patients with spinal cord injury, sepsis, blood inflammation, when bacteria are everywhere, and it's extremely dangerous and extremely challenging to manage. And then, of course, diagnostic criteria, what tests we have to do, or what tests are recommended at the present time in the community to diagnose urinary tract infections. Again, disputable and discussable between the clinicians. I will ask, you have the papers next to you on the chairs. Have three colors. That's right. I will ask my first question. If person have only symptoms, urine cloudy and smelly, do you have infections? What is the color? Show me the color. I want to see how many people will say yes or no. Some say orange, no. Some say green. That's a majority. It's a 50-50. Here you are. 50-50, okay? I will give you another scenario. We have symptoms and we have laboratory data. Person have cloudy, smelly urine, but he or she feels shivering. She feels that she has temperature. And then physician did urine analysis, and urine analysis shows that bacteria is quite high. Does this person have infections? Okay, I see green, more green. Everybody, oh, somebody, you disagree. Looks like you have to see me more often.
It's a trick question now.
So this is a trick question, but this is what reality. And then let's look at definitions that clinicians in different parts of the world with long training in neurology, physiatry, created definitions. If you look on European Association of Urology, there is a difference that count of bacteria 10 in a square versus 10 in a third degree in other definition. For example, American Association requires that you have to have blood in your urine, hematuria, or some hemoglobin presence in your urine. And ISCAS, International Spinal Society, and I'm a member of the society, Dr. Vu is member of the society, Terry and John members of the society as well, also put you have to high level of leukocytes. And leukocytes is the white blood cells which shows that inflammation is present. That's why even though looking on this table, and it's only 3 definitions, I give you example, there is a different opinion in different parts of the world. That's why if we look and compare different definition and possibility of diagnosis of urinary tract infections, you using one definition, there is a very high possibility that person say, okay, you have urinary tract infections, let's start antibiotics. But if you use more serious definition, well, definitely we have to have symptoms, which will be reported by patients. That's why we need your opinion, we need your input. Like Dr. Wu stated, you have to know your baseline, but you also have to have some changes in your body, increase in spasticity, presence of the temperature, maybe start of new urine incontinence. And then physician will add also urine analysis and blood analysis. And then combination will probably give a better answer of urinary tract infections and then decision to treat urinary tract infection. That's why. That's why, what is your suggestions? Are there all of these components has to be present for the diagnosis? Yes, there are. And based on this, if we start to treat only when you come to me, Dr. K, I have a little bit smelly urine, give me Cipro. I will say no. Just based on your smell of urine, it's not urinary tract infections. If I give you every time Cipro, you will develop antibiotic resistant bacteria. And this is what is a challenge, because sometimes in the community, people who don't deal with the people with spinal cord injury, like family physicians, sometimes don't know what to do. Oh, you have smelly urine, let's start. Let's start. Not. And that's why what I would like to mention only in one slide, that antibiotic resistance is a very important and challenging issue. That's why I may ask, how many of you heard about antibiotic resistance or know that you have it? Okay, we see the green papers. Yes, this is a challenge. And you know, like, yes, we doctors will have to prescribe drugs, right? Not always. And particularly with antibiotics, we have to be very careful. So I will go to the last part of my presentation. What are the risk factors that predispose people with spinal cord injury or with any other neurological disorders to develop urinary tract infections? I was fortunate to be invited by Coloplast on this advisory board, and we worked for 2 years with a big international team of people from US, Greece, France. And what we came together, we came with the 4 big pictures, with the 4 big areas where we believe these are contributing factors for people to develop urinary tract infections. First of all, we definitely agree all it is related to catheters. And this is what predominantly I will focus today. There is also a big component, what is general health of person who is using or required bladder management. It could be bowel dysfunctions. Today, Dr. Wood definitely clear. We know you have incontinence with the bowel, you will have higher frequency of urinary tract infections. Aging, with aging or diabetes will predispose you for urinary tract infections, as Dr. Wood said, high sugar going to urine. Bugs love sugar. That's why they will grow in the urine, which is sweet. Then other components, your personal components, how well you learn catheterization technique, how well you clean yourself, or you're using reusable catheters. May I ask how many people here are using reusable catheters? Ouch. We have to talk with you, and we'll talk with you about it. And I will talk about this later. And then, of course, local urinary tract issues. Sometimes, well, we're growing, we're aging, or is growing, and this predisposing us to have more difficulties with catheterization and increased risk of urinary tract infections. But again, I would like to talk with you today mostly about catheters. Let's talk about reusable catheters. Look at this green box. This is a new pristine catheter under electron microscope. This is a study conducted in my laboratory here in Vancouver. And we studied multiple catheters from our population here, people who still use catheters. That's why this first catheter is clean, no scratches, no bugs. Look at the multiple pictures which are present from people who reuse catheter. They use a special cleaning technique and they brought these catheters back. You will see bugs and bugs and bugs. And this is what we're reintroducing back if we do start using catheters. I know some of my patients say, I'm using catheters and I don't have UTI. You are minorities. And one of the things which I would like to address you and emphasize, look at this islet of the catheter. This is the islet catheter, and this has this gunk. This is a gunk epithelium from the bladder. When we insert a catheter, bladder collapsing eventually, and epithelium staying, and this is where bugs like to grow. That's why Dr. K's advice, do not reuse catheters. Let's talk, it's my last portion of the presentation, novel technology. Again, I was fortunate for almost 3 years work with Scholoplots to develop a new type, new idea of catheters. And these catheters have multiple holes, not two big holes typically, but micro hole technology. And what you will see next.
Inside the catheter, we have placed tiny cameras. These allows us to see what happens to the mucosa around the brain itself. As you can see, there is an intense suction of the mucosa into the islets with a conventional islet catheter.
Look at the blood
Which
vessels.
can potentially cause microtrauma.
This is happening every time when we catheterize. We don't have another choice. This is so far was the best catheter.
We have placed tiny cameras.
That's why these two holes catheters, unfortunately, every time when you catheterize it yourself, will have this suctioning of mucosa, which is very gentle. And epithelium will be scrubbed by very polished, actually, edges of these islets of the catheters. And unfortunately, this is what we clearly recognize. This is one of the possibility by people who constantly catheterize themselves, this irritation of the bladder predisposing for urinary tract infections. But another big advantage of this larger catheter, which have multiple holes, that it's allowed better and fully evacuate urine. And I will show you right now, I hope I will show you another video of, you see? That's why look at this, how bladder will empty it with the typical two islet catheters. It starts from the top. Oops, sorry. And this is Lucha. you saw there is still some residual volume left. Did you notice? I will start again. Okay, let's look again on the first portion. Look with two eyelids. It's coming, and then this is stopped because the rest of urine is still staying inside of the bladder. Top was empty, but low portion of the bladder is still full of. Yes, John.
So they got the eyelid of the catheter basically all the way up into the center of the bladder. I'm wondering, does anybody here, when they're putting a catheter in, have the urine start to come out and still keep pushing the tip of the catheter deeper in? I think it's a bit of a false explanation there, Andre. I think most people insert a catheter, as soon as that eyelid passes into the bladder and starts to empty.
That's my exact question. How often you will stop catheterization if bladder stop draining? You see that it stopped? Do you reposition the catheter?
Slowly draw.
How many of you reposition? Few. How many don't reposition?
Slowly draw it out.
That this was shown by multiple types of ultrasound after catheterization with patients who doing it for years. That whatever you feel, oh, I emptied, my catheter was at the bottom. No, it's not, unfortunately. This is reality, that residual volume with the two eyelids catheters still quite high. That's why with a larger catheter, you don't need reposition it because eyelids spread all through the catheter. I have to talk about bladder hours. This is only small portions, like. This is only small portions that I was allowed to talk for 15 minutes. There is many issues, but I'm happy to answer questions in the discussion time.
Thank you so much, Dr. K. First of all, I just wanted to thank our four clinicians, who are all here after their workday to give us a little extra education. So just a round of applause for everybody. And I totally loved the introduction. So as always, we'll have the video of this session up on YouTube with all the names and where you can find people and the handouts. So just my apologies. Okay, we're gonna do a 10-minute Q&A right now with our clinician speakers. We're gonna alternate between online and in person. Okay, any questions in the audience?
Alexis Chicoine. As I'm usually the leader in questions, I don't mean to, but if I put my hand up, then others can follow, so please do. I have two. Well, no, sorry, apologies. The first one was answered. I was also intrigued that sleep apnea has been a standard piece now. I had no idea. I'm 25 years in. I have not heard that before. So,
It wasn't done during your time.
yeah, so thank you for that interesting little piece. Second, artificial sugar. Splendas and things, being aware to be careful of how much intake. Are they, is it both, you know, the two speakers speaking of how important it is to go easy on the sugar due to infections and all the bad things that can come from lots of sugar. Are they as inducing to our bodies?
I'm not a dietitian. And I don't think it's as bad, but it's kind of just as bad for your brain if you're ingesting artificial sugar. Because then your whole taste buds and your endocrine system is a bit off. So then your taste buds, you kind of want more sweetness. So I don't think it's the same as like, you know, sucrose, fructose, but I don't think it's good.
It's still sugar. It's still sugar. Bugs don't care. It's sugars they will grow. They pick up artificial, non-artificial sugars into their colon. Yeah.
Sugars, all the
Dimanose, for example. How many of you taking Dimanose? It's synthetic sugars that our body does not take, but bugs accept it. And that's why they become slippery, because their coating is destroyed by Dimanose. They cannot grow these integrins which adhere to the bladder wall. That's a Dimanose good example. It's artificial sugar. And they accept it, and it's harmful for them, which is good. But other stuff, aspartate, it's grow.
The vitamin D, latest research that's come out about some questions about vitamin D and the amount and or if it's needed now. Have you Is it differing for you at all now? Is it that used to be told to us to do that, those 1,000 milligrams a day? But now there's been some alternate research.
I still believe in vitamin D. It hasn't been, do you recommend it? I mean, like,
In our,
Obviously, it's brand new research, and so who knows?
we don't have anything else to offer people with spinal cord injury with respect to osteoporosis. That's why we really holding for the straw in the ocean. That's a vitamin D not harm you. It's best what we can offer.
My name is Duncan Campbell, and I want to verify something that think I'm aware of, but again, back to the sleep apnea question. My understanding is that anybody with a T5 and up level of injury has a 75 to 80% chance of developing sleep apnea. Is that correct?
75 to 80, so that has been reported, and I forget which time point that was after a spinal cord injury, but right now we're quoting about 60%. Yeah, it's high. And sorry, and the push to get it figured out while you're in rehab or while you're around Vancouver is that there is a sleep clinic, right, at UBC. And people hate the CPAP machine, everybody. But if you are able to get support and fitted and it works for you, like we talk about energy and wakefulness, it's not about that. It's about your heart. Like your heart is working overtime every time you hold your breath. And the severity of sleep apnea, once you have a spinal cord injury, half the time it's going to be severe. So that means 30 times per hour, you're holding your breath. So every other minute of sleep, you're holding your breath enough that your oxygen drops. Like that's a lot of work for your heart every single night. Thanks, Duncan. I didn't pay him to ask that.
I have two questions I'd like to ask. Did you say, doctor, that the pneumococcal vaccine should be renewed every 5 years?
I think so. There's two types. The first one is good for 5 years. And then the second one, I forget. It has different valence.
Length effect, yeah.
Yeah.
Most commonly 5 years.
The other question I wanted to ask, can you give us some idea about fruits and vegetables that are rich in calcium?
No, I cannot. I think that's a simple Google search, if you don't mind. Yeah. What? 811? The nurse helpline?
Yeah, they have a dietitian line.
Oh, there you go.
811 is the old dial a dietitian is all on the Health BC line. We have an online question. Oh, right.
Hey Siri, read vegetables with calcium.
The people online, didn't hear what
Hey,
you said,
Siri.
Dr. Vu, about SNAP.
Hi, vegetables with
The
calcium.
relationship, it's not like a direct relationship that we have figured out or have concluded, but it's associated with an injury. People have described
Sounds
sleep
right.
apnea at every level following spinal cord injury, but especially in the neck, right? If you have an injury in the neck, bones break, muscles, especially if you have surgery after, there's a lot of swelling that happens. So when you go to lie down, all of that swelling, swollen tissue takes up space, and then the airways collapse to cause an obstructive sleep apnea. The nasal passages also become swollen, and again, leads to sleep apnea. So there's two types, obstructive sleep apnea and central sleep apnea. There's a scientist in Michigan who thinks that if you have a tetraplegia, that you're at higher risk for central sleep apnea. So that's still being figured out.
Sorry, broccoli, okra, kale, bok choy.
Yum.
A handout from the Osteoporosis Society that has foods rich in vitamins and calcium, so we can put that in the package.
Can we all add to, that's different, like eating foods rich in calcium is different from taking a pill that's calcium supplements, because what they've seen is the calcium gets deposited into blood vessels, which we don't want, right? So it's really important to have the calcium in your food.
I personally, I don't know if anyone can hear me, but I was recently diagnosed.
No, you need to speak.
Hi, I'm Kirsten. That's really loud. I was recently diagnosed with thyroid disorder. I've been tested my whole life. TSH was fine, but then they did the T3 free and T4 free. Anyway, going on thyroid meds has literally changed my life. Like I've saved $40 a month in heating, etc. But I always thought it was SCI related. But then I'd heard some rumblings that high thoracic injuries and cervical injuries can have a connection with thyroid. Is there anything to that?
No, we typically we don't here. We worry about parathyroid with respect of osteoporosis, but thyroids happening independently.
Hypothyroidism is very common with or without spinal cord injury. It's the #1 medication, I think, the Synthroid. Yeah.
Somebody else, questions?
I'm Joan. And I was gonna ask,
Can you hold the mic a little closer to your, like, right by your
like that?
Yeah.
Oh my gosh. Okay, I'm Joan. I'm a C4 to T1. It used to be called, I guess, incomplete, is tetraplegic now. That's the word.
Correct, incomplete tetraplegia.
And, well, all the things that you were talking about, I have, but I don't have any help or anybody's helping me or anything. How do you start doing that kind of thing?
Who is your physiatrist?
I don't have one.
So you have to have physiatrist first.
How do I get one?
GP has to refer you either to outpatient clinic at the GF Strong or at the Blossom Pavilion Spinal Cord Injury Center. And we have whole team of outpatient clinicians, depending where is your home, Vancouver or outside?
Very close to here.
Okay, so then there is a possibility to find support through the community and through the social worker. We can also, the BCSCI, we can also support you to find support how programs will be available.
Can I ask if the GP doesn't want to refer you anywhere?
He cannot. You
Not
have to
refuse?
refuse. He cannot refuse. And we're not refusing patients with referral.
Thank you.
Yeah.
Tell him Dr. K said he needs.
Yeah.
If you don't have a GP, can like urgent care clinic or
Sorry?
like if you don't have family GP, it's something we both.
Then there usually nurse practitioner or whoever, somebody has to. Unfortunately, we need referral.
Walk-in clinic.
Yeah, walking clinic, exactly. Yes, please.
I have a question about cranberry,
Hold it up by your mouth.
cranberry for UTI, please.
Very good question. Cranberry juice from Costco is crap.
Yeah.
Don't buy. But there is definitely evidence in able-bodied populations that cranberry extract, very high concentrated juice, does decrease bacterial growth in the bladder. That's why for many of my patients, I do know that cranberry extract in the tablets, which is much easier for stomach, cranberry extract juice, which is very concentrated, sometimes will cause gastritis. That's why you have to try which you can tolerate. And there is lately available combination of cranberry extract in a pill together with D-mannose. And then you're killing two birds with one stone. That's it's useful. Absolutely. But drink water. Drink water, what Dr. Wu said, water, water, and water. 2.5 liters a day, at least. 2.5. If you're catheterizing. If you have Foley catheter, you can drink slightly more. No coffee count. Mine is not count. Liquid water.
We have one last question and then we have to move on to our panel. Thank you again all so much. Okay, here's a question.
I have a question. So Dr. K, you mentioned that some people who reuse catheters don't seem to get bladder infections. This is the minority, you said. Do you know why? Please.
Good question. I don't. But again, telling that I never have urinary tract infections, person who are using catheters, I see people definitely very tolerant to their symptoms. They do have urinary tract infections, but they're just ignoring it. Or they learn how to add a little bit water or a little bit diamonose and evaluate and eliminate these issues.
So do you think if they're non-symptomatic but still have bugs in their system, there's like,
Oh, we all have
like they
bugs.
have bugs, but is that like a precursor, you know, I'm worried about like bladder cancer and things like that. Like, is there a point where you may not be symptomatic, but it still could be dangerous
Yeah.
for your bladder?
So that any person who catheterized bladder, what we call have colonization. Bacteria will be inside of your bladder in comparison with people who never catheterize themselves. But level of the bugs and what is the quality of the bugs? Because some of them pathogenic, they could create infections that predispose for infections. And obviously, this is a possible risk for the cancer.
Okay, thank you.
Please.
Sorry, we've got to move on. We
Thank you
definitely
very
get
much.
answers
Thank you.
For you after, but we're gonna move on to our panel. Thank you all so much. Can I have Duncan and our peer panel?
Hi, my name's Duncan. You already heard my name over there, asking about sleep apnea. I was injured, C7 product from Dick in 1973. So you probably weren't even born then, but you know, it's been a long time. Been in a chair for about 50 years. And about 5 years ago, I had a lot of trouble. In those 45 years before that, I had barely any trouble. I was doing things that I probably shouldn't have done. I probably did a lot of things that I shouldn't have done. And when I hit 60, things started to, you know, get a little iffy. And of course, my attitude wasn't the best. I'll admit that very freely. I was too tough to think that anything could go wrong. I was a little too macho for that. You know, I was a wheelchair rugby player. And, you know, I wasn't going to have anything go wrong. And then everything went wrong. Good. So I had about 3 years of really rough now. Rough enough that I almost tipped it. It was close. At the same time, like before that, I had 2 kids. So when I got close to kicking it, I was not going to kick it. My kids were there. I had to be there for them. So we got through all that. And then I'm a retired guy with 2 kids. I get my kids through COVID, you know, I'm a daddy daycare for a little while. And then I started getting bored. Like, I'm not used to being retired. I worked all my life. I got nothing to do. I'm thinking, what am I going to do? What am I going to do? So, Chris McBride ran into my wife, who worked at Jeff talking about, and asked her how I was doing. And she told me that I was bored. I needed something to do. So he actually offered me a job and asked me what I would like to do. And what I said I would like to do is to help other people not run into the problems I ran into. So to operate a program that'll give people advice on how to avoid the things that I didn't avoid. And I'm not saying I could have, I probably could have avoided a lot of them. But there's lots of things that you can do to avoid them. And these people that are up here with me, Kristen and Hillary and Barry, are also here to tell you about things that they've thought about, they thought they can change to make their lives healthier and longer in the long run. Okay, and no one wants to start. They've all said, I don't want to go first. I don't want to go first. So I'll go first. And I'll go right back to the sleep apnea issue that we were discussing earlier, which was one of the things that almost got me. And I have to say that Dr. Vu actually tested me for sleep apnea when I was in the hospital for something else. Told me I had it, and let me try the masks and the CPAP machine, and I hated it. They were really awkward, they felt terrible, I couldn't sleep. So I just said, well, I'm not doing this. It's not gonna happen to me anyway. That's what my head, that's the way my head's been. It's not gonna happen to me. Well, you know, you don't realize it because it happens to you at night when you're supposedly sleeping. But if you don't sleep well, you're waking up in the middle of the night. If you're getting tired in the middle of the day, if you're, you know, starting to talk about things that, you know, you're not really sure what you're talking about, those things all happen with sleep apnea, but you don't really notice. You have to have somebody else notice for you. And what happened with me is I ignored it for probably 3 years. And then I got pneumonia, and combined with the sleep apnea, I was, boom, gone. They took me to emergency. I woke up with a trach around. And I think it's called the breathing. Yeah, thing they put it's the most barbaric thing I've ever seen in my life. You have to chew on this thing and you can't talk, and it's a breathing tube, basically. And they got me through it, and I went immediately on to the BiPAP machine. And now, I can't sleep without it, you know, like, I gotta have it. And I don't mean that like I gotta have it like it's a terrible thing. I gotta have it because it helps me sleep. And I feel better, I feel more energetic. I feel everything is, you know, in my mind, everything's fixed again, there's my life. But that is something that if you have any hint that you might have sleep apnea, get checked out. Because it's not just something to smooth over. I don't think the risk of what can happen is out there enough, is what I'm trying to say. To me, I didn't know that sleep apnea could do this to me. And people need to know. Not to scare you, but just to make sure that you do what you need to do so that, boom, it's not going to affect you the way it did me. Okay, and again, that's why I asked Dr. Bruder to verify the 75 to 80%, especially clots. Look up. Okay, just get checked. And the masks nowadays are a lot easier to use. I'm totally independent with mine. They're more comfortable, all those things. It's not a terrible thing. They're not noisy. I doesn't keep my wife away, it doesn't keep my kids away. None of that kind of stuff. So that was kind of what I wanted to start with. If you guys know what they can do. And with that, I think I'll, does anybody want to volunteer to go first, or shall I just want somebody else?
I'm ready to go, Doug.
There we go. Hillary Brown. Hillary Brown is an old friend of mine for, I don't know, 30 years or so. Mostly from playing hockey. We played pickup hockey in the summer, like street hockey, for years and years and years. It wasn't organized with sports or anything. It was just a bunch of guys that did it. So I'll leave it over to Hillary. Hillary, get that.
Thank you, Doug. Yeah, I've known Doug for a long time. We live in the same neighborhood. I see him on the street, and the other day he asked me if I'd participate in this discussion panel and suggested a topic for me. So I thought about the topic, and I made some notes, and I brought my book, but I'm going to change the topic because we've been discussing some more interesting things, something that I've got a bit of a passion for and a little bit of experience with, and that is UTI and antibiotic resistance. So let me go through my track record from the very beginning. I'll try to make it brief. But I was in GF 35 years ago. It's probably only a few weeks in there before I had my first UTI. And then I had 30 years of UTI. I was popping antibiotics like they were Pez. I would borrow them from friends. I was taking them without testing. You know, but when you're sick, you don't care. You will take anything to get better. And at the time, resistance wasn't a big thing. Yeah, big mistake, right? So eventually I became, or my bugs became resistant to the Cipro, to the Keflex that I was using on a regular basis. I'm also allergic to a few antibiotics. So the number of guns they had available to defeat these bugs were becoming fewer and fewer. I eventually ended up having to go to St. Paul's for antibiotic IV treatment. And that's a real drag. That's a few trips a week, sitting in a ward, a very interesting ward, in fact. But at this point, I was getting attention from a infectious disease expert. So I started asking questions about the resistance and the bugs and whatnot. And I was told this: we can get rid of the bug you have, but a new bug will come along. And it's just luck of the draw. Are you going to get a bad one with a lot of virulence? a lot of disease causing properties, or are you gonna get one of these more friendly fellows? Well, I've not used antibiotics for 5 years. I can clearly tell you that my bladder's populated, it's cloudy, sometimes it smells, but it's manageable, and it's manageable because I'm very cautious now. Water, water, water. That's all I can tell you. More water.
Barry, want to go? This is Barry.
Hello, everyone. My name is Barry. I am a C5 incomplete. Almost 14 years post-injury now. Like Hillary, my big issue after I was discharged from GF was also bladder management, UTIs and whatnot. And I would say my biggest takeaway is to educate yourself as much as possible about your level of injury. Like Dr. Vu said, what your baselines are, because you're probably the best person to diagnose yourself if you are experiencing symptoms, if you are experiencing UTIs. I would say educating yourself as much as possible about your level of injury, the medications that you're taking, the symptoms that you could be experiencing, side effects from them. Luckily, I had great peers, like these guys up here, SCI BC, like Terry and Ryan. I probably harassed them for the first 2 years after I was discharged, asking them a lot of questions because I wanted to learn how to better manage my bladder because I was having lots of UTIs, et cetera, et cetera. And through asking questions and asking clinicians, medical professionals, about ways I can better manage that, it helped build my confidence and help me build my self-management skills in general as someone living with SCI. For example, through participating in studies at ICORD, referral from Terry, that you could actually, there was a study to get Botox injections to treat your neurogenic bladder. So that was the first thing that I actually probably signed up for as a here at ICORD, which was great because with Botox, I no longer had to take oxybutynin to treat my neurogenic bladder, which was causing me lots of side effects. And there was no really side effects from the Botox. I could do my in and out catheters, no problem. So that was great. That was like a huge plus because it gave me the confidence that I could do my in and outs whenever I wanted to. Also, a referral from SCI BC was a program that Coloplast actually has, where you can actually have some samples, like for catheters, because we all have different level of injury, our level of function is different, so you could actually test what catheter works for you and your function level. So I think that's a really great resource to, ask SCI or check out SCI BC's website, because that program is actually on the website. So take advantage of that. And I would say being more proactive. I request a requisition from my GP for a urine sample. So when I am experiencing symptoms, I can do a sample at home, take it to my lab, and find out in fact whether I do have a UTI or not. Then I can get medication. So being really proactive about things and managing your overall SCI health might help you out as well. And I'll pass it on to Kristen.
I think I may have inherited Duncan's stubbornness, whether it was from his teachings in GS Strong or otherwise. My name's Kirsten Sharp. If you don't know me, I'm a 1 or 4 complete, depends who you ask. I've been doing this for 34 years and was injured when I was 14, which I think makes you kind of resistant and stubborn and willing to do anything you can. And I remember my last day at GF Strong, Duncan said to me, "You're not leaving this hospital until you get in and out of that bathtub on your own with no lift." I was going home with a lift. I did not go home with a lift because of this man. So now I'm gonna let me know last year. But the reason I mentioned that is I think the physios at GF Strong were extremely intelligent. Listen to them. When I was a kid, they literally scared it into me. You're gonna need a power chair, etc. And Dr. Vu alluded to the fact that we have so many other options now that are cooler and neat, and there's, you know, engineers who we're gonna make something really cool. I mean, we have one in the building with Jamie Borisov, and we are so lucky to live in BC, which is like just this mecca of spinal cord injury and information. And I would ask you to ask questions, listen, very much listen, don't always come back with an answer, educate yourself as much as you can, and advocate, because often we go and see a medical doctor and they don't listen to us. The amount of times I've been misdiagnosed, mostly because they're looking at the chair, and I know that, you know, in life people that have obesity issues have the same sort of problem. Someone goes to a doctor and you need to lose weight. Well, that's not gonna fix my problem because maybe I have a brain bleed. But I find that happens to us all the time as people with spinal cord injury, and we're having an issue. I had bladder infections, we talk about that, but I had 17 a year for 9 years, and I just got told you're capping wrong, you're doing all this. I went to Steve, I learned a lot about catheters, I learned a lot about polished catheters and eyelets and et cetera, et cetera, et cetera. What I found out in the end was I was going through very, very early menopause, and my estrogen levels were very low. I went on estrogen replacement, and I now get a max of 3 infections a year. Now, I'm telling this story more because we are still people. We may have spinal cord injuries, but we are still going to have heart issues. We are still going to have sleep issues. I've been at the sleep clinic. I've slept there 4 nights in my life. It's not fun. It needs to be a little more accessible. I have an ulcer in my bowel at the moment, which is likely from DigiStim most of my life, but finding that out, I had to do the colonoscopy, like Dr. Vu says, and then I had to also do that scary thing that you mentioned, is change, and I had to think to myself, okay, I've been doing DigiStim for, I think it was like 27 years at that point. Then I was about to have carpal tunnel surgery. I'm like, how am I going to go to the bathroom? How am I going to be independent? How am I going to transfer? So I started using the Magic Bullet suppository, changing the fingers that I was using to do the DigiStim, and then doing colonoscopies. And then after seeing the gastroenterologist, he's like, you need to start doing your routine every day because your stool is sitting there and it's causing this ulcer. So I get repeat colonoscopies, as well as I'm forgetting his name because of my menopause brain, but the one that doesn't go all the way up. Anyway, sigmoid, which has shown that I still have this ulcer, but I had to change my routine. I do go every day. I've been able to reduce that amount of time to about 30 to 40 minutes from about an hour and a half. So it's very inconvenient because I do work full time. So, you know, spending that much time on the toilet every day is tiresome. Yes.
Can you talk about your bowel prep for colonoscopy? Because that's really hard for folks.
Yes.
Can you answer the question with the question in the microphone?
Yes, so the bowel prep for a colonoscopy is not fun. It is horrendous. It feels horrendous. The amount of stomach pain you'll go is not fun. I am very lucky. I don't know how I've done it, but I've always put a suppository in when I'm not sitting on the toilet. So I've used AD to my advantage, sort of when I'm getting sort of like spasm or goosebumps, then I'll know that that's when I have to transfer onto the toilet, which has lessened my time sitting there on a plastic piece of whatever. So I'm lucky that I've learned my body and I know the signs of when I'm going to have a spasm or when there's going to be some sort of movement. So with the bowel prep, I was able to use those signs after drinking it. But yes, definitely put a towel on your chair and be prepared to spend a few hours sitting on that toilet. I would also say, you know, the gastroenterologist said to me that because we do have spinal cord injury and because we do technically clean out a little bit more often, you know, if you can't stomach a sip, don't take that as medical advice though, because also they cannot perform it if you are not clean and it's a waste of time. So yeah, it is, there's a lot to it. And then, you know, I was told as a kid, you're gonna need this, you're gonna need that, you're gonna need this, and I have needed all those things. I've been very lucky to avoid those pressure sores, but I just had a very serious wound on my ankle, which again, I was stubborn. I'm like, I don't need to go to the hospital. And finally I saw a doctor and they were like, oh yeah, that's not good. And it did take about 3 months to heal. It was probably only this big and it was a burn from a heating pad. Not smart. Yeah, watch those heating pads. Yeah, and we've all sort of been there, but I think my biggest piece of advice is be your own advocate. If someone tells you that it's because of one thing and you think it's not, like Barry said, you know, like you're obviously not a doctor, you can't diagnose it, but you're feeling something and you have those feelings. Another example of that was I had what they thought was nerve pain in my leg and it turned out to be endometriosis after surgery. So it just, we are still human with SCI. It doesn't mean that everything is going to be related to SCI.
You don't get an exemption from the,
No.
from all the other stuff. Can I ask a question? Thanks. Thanks to you guys for the, sharing all those stories. I have one question for Kirsten, but I think anyone else who wants to respond. If you self-professed stubborn, so if you could speak to stubborn Kirsten as current Kirsten, like after you've done these things to make your life a little easier or to advocate for yourself or to, you know, poop every day, what would you say to her about how that has affected your life, making those changes? Do a little psychology for you.
I have to be completely honest, and physios probably wouldn't like my answer.
Fired.
I would not change how I've like got in and out of a bathtub or done those things. I say that now with a tear in my shoulder and like the inability to move last October, and now I do need like a lift, etc. But I would really suggest live your life, take smart risks, make smart choices, be open to using that bath bench or the sliding hood when you need it. Also, you know, listen to the money thing, but also live your life. Like I would not have traveled or done the things that I've done if I hadn't had like Duncan as my mentor or learned from other people that these things were possible. But I also would have like, when it came to bowel, etc., I'm like, yes, I should have followed those health and I would have told the person, listen.
I kind of agree with you and disagree with you at the same time, Kirsten. I think that learning those skills for independence so that if those accessible options aren't available, like a bath bench, being able to transfer into a bathtub is a really important skill to have. But if you don't need to transfer into the bathtub, if you can get a bath bench at home, use it. You know, have the skills to do what you need to do when you need to do it. But, you know, use the accessible adaptions that we have available to us as much as possible, because, you know, as our great physio friends showed us, you know, you've only got so much room in the bank. And if you can save stuff in the bank, then it's available when you need it later.
I just want to have a little response to that. I just want to point out to John especially that 20, 30 years ago, those things didn't exist.
Yes.
So I learned how to do these things. I probably wasn't supposed to do them either. My OT, when I went through rehab, was fantastic. She was unbelievable because she let me try things that I wasn't supposed to do in the book. You know, the Duckworth book. Said what you could do if you're this level, what you couldn't do, and all that. And I refused. Again, the stubborn stuff, refused to let that stop me. Now, if I was injured now, the same way, I would look at those things and use them. Yes, I would. But I would also want to know how to do without them. Because if you need them, if you go through your rehab so that you absolutely need those things and don't know how to do without it, you're gonna be very restricted in some of the things you can do with your life. So, I mean, I was lucky, in a way, I've said it to many people. I lived through 50 years of vast, amazing development for people with disabilities. Unbelievable stuff. I mean, almost nothing existed when I was first. There was no hand guard, there were no curb cuts, none of it, all there now. So, get used to it, but it's still coming, more is coming.
We have a Vivian and then a Viet and then an online question.
Okay.
So I noticed that Dr. K used technology. And it seems to be a big innovation now. And my question to all of you is, you've been in chairs for a long time. Are you adapting with any technology? Sorry. Are you using technology at all in your daily living to do anything?
I will answer, I'll let you answer first. I can tell you that I am, and I have used things over the years, like different things. At one point I was using an aqualift in the tub. You get in, then you go down, you go back up, and that kind of thing. Recreationally, I have been involved in technological developments all along. Like one of my passions was riding a hand cycle. Well, we started when hand cycles really were kind of crappy, maybe were terrible, but we tried them anyway. Until we got to the point where they were really good, and we were riding 50K on a ride, but it was because the technology was getting better and better and better. And now the power assist movement is coming along, the data movement. And those things, they're not just recreational though. You can use those to manage your life and make a longer history for your shoulders. Like if I had a power assist and didn't wheel up every hill I saw and used the power assist to get up the hill, I don't know. I'm already 68, so I don't know if I would last any longer, but it might help, right? Or if I had known that I should do something with a sliding board, which I never did. Okay,
Are
sorry.
you still using the Prism, the lift, the self?
Yes, I didn't go into that, but I use an overhead lift as well, getting out of bed now. Because I ran into problems with wounds because my transfers were so bad because I threw my shoulder out. I got a whole bunch of things I could go on and on. But I use an overhead lift, and I have something called an independent lifter, which allows me to do it without a sling. So I can do it myself. I got in and out of bed 2 or 3 times a day.
And not just fancy recreational stuff, like all of the environmental control units to open the door, when you use voice control to turn off the lights, like that's technology.
Yeah.
Ordering groceries.
Groceries, yeah.
Kerosene for the bottle.
The Parastene for bowel care, it's very expensive, but it works well. I wanted to comment about doing stuff and not doing stuff. It's not black and white, right? Like the therapist will tell you, know how to transfer without a board for emergencies.
Yes.
Yeah. But that's not to say don't practice it. Practice it so you know it when you don't have a board. But for the majority of time, you will use a board, right? So
Work smarter, not harder is what I'm telling you. And have the skills that you can do anything you need to on your worst. Have skills so you know how to do anything that you need to be able to do. But then, if you have an easier way of doing it, work smarter, not harder. What's the point of tiring yourself out for no reason, doing transfers when you can tire yourself out doing fun stuff?
Sorry, we have some of them. Been very wrong. Thank you.
I think just to sort of reiterate the notion of trusting your own sense of self and your own body, and knowing that even if you're not sure what's happening, if you think there is something bad happening, to get checked. When I was, it was a few years ago now in 2022, I didn't know what was going on, but there was something going on. And I ended up calling an ambulance, and it turned out I was having a heart attack. And I was only in my mid-50s at the time. And didn't have any indicators that I should be having a heart attack at the time. I was normal blood pressure and all that jazz. Turned out there was some issues in my family that would indicate such. And I did have sleep apnea that I didn't know about. But it is important to pay attention to these things and to deal with these things. I was very lucky that I did call the ambulance and I was able to get it dealt with and get stents put in and so forth, and move forward and deal with the things that need to be dealt with. But if you do get things that don't make sense, even if it doesn't feel like a heart attack, get it dealt with.
I mean, that's a great point. And we were joking about this just before we started that or I guess just now, we don't get an exemption from the non-SCI stuff. Like the, heart problems and stuff. In many cases, it's also related, but,
I just want to move back to this question about technology. Anybody in the room experience spinal cord stimulation?
Yes.
Okay. So this is something which is coming. It's not yet easily available, but I can tell you from 45 years working with spinal cord injury, I never saw in my life so dramatic changes in some of my patients who went through the spinal cord stimulation with various benefits. 5 out of 20 who completed trials in my laboratory in Vancouver showed a recovery of motor function 10 to 15 years after spinal cord injury. Nothing before was able to produce this. Hand function improved dramatically in people who participated in a clinical trial. And just a couple of weeks ago, this device was approved by FDA for clinical use. We're waiting when this device will come to Canada, but there is definitely follow-up with technology. Technology is incredible, incredible.
The one thing I would add myself as well is that, I was one of those people that really had opinions about what technology to use. And I was like, no, I'm never going to use an electric assist on a hand cycle. That's cheating. Why would I do that? I need to like muscle it. And as a result, I didn't cycle. So for me, like deciding to use the help got me in doing more physical activity. And, through the 3 years of our cycling program, we've seen that too. That bump made it doable for more people to try it as a form of physical activity and recreation and being with their families, being out and social and enjoying the sun and all that good stuff. And so I think we think of technology or like help as an all or nothing thing, but sometimes it's a step that makes the rest of it much more doable or safer or contributing to your bone and joint health. So there's that too.
First, just want to respond to what Dr. Payne was talking about with neuromodulation, spinal cord stimulation. We did an amazing 2-day symposium with SCI BC just last week. Dr. Payne was there, Dr. Elliott, we had amazing speakers. So if you want to learn about neuromodulation, epidural stimulation, transcutaneous stimulation, things like Neuralink and brain machine interfaces, we had some world-class speakers. So definitely check out the YouTube page on SCI BC to learn more. But I wanted to ask Duncan, one of the things that I've seen happen quite frequently is people, as we get older, we get used to living our lives the way we've learned to with our spinal cord injuries. And I hear about this so many times where there's one incident, one triggering factor, a bad transfer, an injury to a shoulder or a wrist, a small wound on a heel that ends up causing a cascade of things happening in sequence of it. You do a bad transfer because you injured your shoulder. That shoulder injury causes a bad transfer, causes a fall. The fall causes a wound. The wound causes a fracture. Could you maybe talk a little bit about those experiences about how one small thing causes a massive cascade, and if we perhaps invited more adaptive equipment into our lives a little bit earlier, might not have caused that triggering incident?
Well, I can address that one from my own perspective, and it was one incident where, again, I probably could have prevented it, but didn't. I did a transfer into a vehicle that was too far. It was just too far. It was dumb, but I'm going to do it, and I blew my shoulder out. And I really blew it bad. So that ended up making it so I couldn't transfer it off. So then I started rubbing my ass on my wheel when I transferred. So then I got a wound. And it just, you're right, it just cascaded. And then other things happened. Because I wasn't getting as much exercise, other things happened. It was a catastrophe. That was the start of it all. With one little incident where I could have probably just used a sliding board and I would have been fine. But, you know, I wasn't, I don't know, I wasn't brought up with that attitude in the days when I was hurt, but I didn't have that attitude. I had the attitude, I do anything, I'm gonna keep doing it. You know, I was a teenager in his 50-year-old body, which was probably not quite a thing to do. But, you know, I know that now. So too late, it's not too late, I'm still kicking, but, you know, I could have probably done better. And it was one little incident. You guys have anything along those lines?
Duncan, can you tell a story when you noticed some new weakness in your body, which was something different, and you did not want to leave emergency room for the reason?
Oh, no, way back.
I know, but this is what about the listen.
Now, this is a story from way back. This isn't from my aged area. What I call my aged area. This was from, I think I was about 40 at the time. I have to say I had a really good GP. I had a GP who found serums in my spinal column, told me about it, I went into his office and said, I'm getting a little weak in my arm or something. So he found it and he said, it might affect you, it might not. If it does, if you start to get weak at any point, go to Amrit, tell him what's going on. So it didn't affect me for, I don't know, 5 or 6 years, nothing happened. And then over 3 days, I went from riding my bike, driving my car, helping with transportation at a wheelchair rugby tournament, to not being able to drive the car, not being able to turn the steering wheel, not being able to get in and out of bed. And I went to Amrit. I told them, like, I have surgery, and this is what's happening. And they were going to give me pain meds and send me home. And I said, I'm not going. Forget it. I know what's going on here. I can't live in it. You're not sending me home with pain meds. And this was an emergency. And I don't know this for sure, but I think they called me. Okay.
You called me.
It wasn't me.
You called.
I was out of it, you know, but I wasn't going anywhere. And he told them that, you know, this guy doesn't come in unless there's something really wrong. So, you know, and I ended up having a laminectomy, which is a 5-hour surgery on your neck to get serums out and clean your spinal column. And I was really lucky because it worked. The guy that did it was fantastic, Dr. Maffin. And I ended up back on the road exactly how I was after about 3 months in their rehab, and then I was back on the road for another 10 years or something with no problem. But yeah, but it was because my GP identified it, and I knew what it was, and I, as you were saying, I advocated for myself. I said, I'm not going. You're not sending me home with papers.
Okay, next question to Alexis.
It's not entirely a question, but a recognition that not all of us leading GF have the ability to transfer to a back, into a back. We should be able to do the transfer to the van or the driver's seat on their own. Being 5'1" now and short and solid, and learned I have shorter arms. And when I was doing physio, I'm like, what do you mean? Lift myself, and I put my hands down beside me. I'm like, there's no lifting me. So I had to embrace the sliding board and these other features. But I wanted to mention that embracing some of these features, and I use a commode chair at home, which is amazing because I can, yes, I had to design my bathroom around it. But I could roll to the toilet, I could roll to the shower. I transfer independently from it to bed. But I travel with one. Yes, it needs more gadgets, but it hasn't stopped my life. And it just means a little heavier luggage, but that luggage is free. So you just tell that airline, not paying for this one, this is adapted equipment. So I want to encourage, even if as you're having to pick up these pieces as you are aging, it will not stop you. It just means doing things differently. And it's been, yes, I actually too have tears in my shoulders after 25 years. But that was a lot of sport and I had a blast doing it. But still being able to zip line as a C6 quadriplegic. Sometimes it's a gadget, sometimes it's people that you can lean on a little bit to be able to do these opportunities that are out there. So it's pretty awesome. And thank you as well as the panel for sharing the tour.
Excellent. This is a great session here. Duncan, completely agree with you on the equipment side of things. I was in the equipment industry for a number of years and always said you're only as good as your equipment. However, at the same time, I agree with you on that. There's a lot of times where you see people coming home from GF and, you know, typically if they have an abundance of funding, all of a sudden they've got grab bars and lifts and everything absolutely outfitted, retrofitted all over the place, which in some cases can be a hindrance, right? So when you're traveling, you know, get a hotel down the street here and you don't have those grab bars and everything all over the place. However, you can, you know, get dressed and such independently if you've practiced it. Can make a difference, right? So when I say you're only as good as your equipment, as you're aging with spinal cord injury, you know, embracing those, you know, little tools or sliding boards or whatever it is, of course, is something that we definitely have to overcome. I think the biggest thing that I've seen over the last decade is the lithium age. We are in a whole different ballgame now. Like Jocelyn was saying there with the power assist on hand cycles. I mean, we've got front drives, we've got smart drives, we've got you know, bow heads, we've got hub drives, we've even got caster drives. Like this is a whole different ballgame where, you know, for most of us that are using manual chairs, you know, we're looking to the future and it's like, you know, most likely it's inevitable. Power is inevitable. However, with these new devices that have been starting to come around the last 5 years, we can stay in what would be somewhat of a manual chair, but of course, just add power to it. So then we're not having to change necessarily our entire environment, our transportation and all that. So I think the future is looking pretty good.
Okay, last comment for the doctor. I just want to say, like, we have a ton of plethora of equipment at our fingertips, but some of us here didn't have that when we were first injured. Be curious, think outside the box, do things for yourself. I recently had an injury on my heel. I took my beloved Converse and I cut it in half and put tape so that there was nothing on it. When I was first injured, I really wanted to wear jeans. I was 14, wanted to fit in. So I had them altered so that there was a zipper that went all the way to the back because I couldn't take them off at school. That way I could still fit in and catheterize at school. Think about the things you need and how you could adapt something for yourself if it doesn't exist, just to get out there.
And I think you just said what I would really like everybody to hear, is that you guys have the opportunity to use this stuff, which I have to say I didn't. But, you know, if I could have, I would have. Like a power assist on your manual chair is, it's nothing to worry about. It's just gonna help you. You don't have to use it all the time. You don't, just use it when you need it. And that kind of stuff is gonna help you in the long run.
I just want to thank our panelists and our facilitator, Duncan.
It would have been any fun if you hadn't asked all the questions.
And if you learned something today, or if you're inspired to make a change that might help you think through how to make it, what help you need to do that, what plan you can make, and how to check in with someone, even yourself. How am I doing on this? Because making a change is a learning process, and you can get back to yourself, learn something from it, and try again. I also want to mention that we have essentially turned that into the peer coaching program. And I said we, but I really mean Barry and Terry and Mary. So if you want to work on something, any kind of change, skill, etc., with a peer over a period of time, we have a peer coaching program, and that is exactly what it's for. It's free. Terry runs it, and it's a great way if you want to just have some accountability and a reminder to focus on something that you need to change. Maybe it's like increasing your water intake, doing more physical activity, eating less sugar. I think of the other things we talked about. Adding to your shoulder bank. All of those things are totally fair game, and I'm sure that we each have something that we probably could work on with a coach as well. So there's flyers at the table in the front, and if you missed it or you want to talk to someone further about it, you can just respond to the email that you found out about this from, or grab one of the many SCI BC staff who are here. And Terry's over there in the leather jacket, so she'd be a good person to talk to about it. Oh, yeah. Geez, thank you for the reminder. Info line is 1-800-689-2477. It was info@sci-bc.ca, and we will help you find the whatever support or info you need. And again, one last round of applause for all of our contributors. Thank you.